Okay, thank you for this very nice introduction. And it's my pleasure to have the opportunity to present in front of this audience. And what I'm going to talk about is quantification in renal scintigraphy. It's a topic that I feel that is not really utilized in presentation for the last while. So I hope to present something that will be try and make a new subject, an old subject new. So first, I have no disclosure that's pertinent to this presentation. The objectives is to familiarize with the non-imaging modalities to assess renal function, and also to understand the method using radionuclide to estimate the GFR and the estimated renal plasma flow, and correlate the findings on renal scintigraphy with estimation of renal function if time permits. And finally, to identify some of the pitfalls that can confound the results that we obtain. So common non-imaging modalities to assess renal function. I think of the words, serum creatinine, serum urea, and I'll mention briefly about cystatin C level, 24-hour urine creatinine clearance, and ileum clearance. So serum urea level is by itself, it's not a very reliable method for estimation of renal function because its level is greatly affected by non-GFR related factors, namely dehydration, alcohol intake, high protein diet, medications. But if we use it with serum creatinine level, we can narrow down the differential diagnosis based on pre-renal and parenchymal renal disease and post-renal causes, depending on what is the urea to creatinine ratio in the serum. And the serum creatinine level, this is one of the most popular determinant of GFR, but it also comes with limitation. We could actually determine the GFR or estimate the GFR based on the body mass, gender, and age. There is the Koch and Gault formula that could determine the GFR based on those three parameters that I mentioned. However, there are some confounding factors for serum creatinine levels, including high muscle mass. So not every person who is 239 pounds is equal. There's creatine supplementation that can cause elevation of serum creatinine with not necessarily impaired renal function. And then high-intensity exercise, rhabdomyolysis, dehydration, and medications can also cause elevation of serum creatinine level unrelated to renal insufficiency. Now, the problem with serum creatinine level, it is not reliable for acute renal failure because it's not in a steady state. It takes a long time for the creatinine level to go up in the blood. But if it is a steady state, it is good. But it's only good for stage 3 renal failure and worse. So that's why if the GFR is 60 milliliters or greater, then this is not a sensitive test for early renal failure. But it has the advantage of being easily accessible and being inexpensive. And finally, there's a high intra-individual variation of creatinine excretion, and there is up to 25% coefficient of variation despite having stable renal function with the creatinine clearance. And the 24-hour urine collection is considered as, quote, the best test that can be used, but There are some limitations as well. It's not reliable for acute renal failure because it's not in a steady state. And there's a small amount of tubular excretion of creatinine. So a particular GFR that is very low, less than 30, the tubular excretion start to become a more important contribution of the creatinine clearance, and that can cause overestimation of the GFR. Then, not to mention, there's also patient-related factors, the inaccuracy of urine collection, and it does not actually assess what is the individual renal function. But it is an inexpensive test and still more reliable than just a single serum creatinine level. Now, I'll just briefly mention the cystatin C level. It is formed at a constant rate, and it is a blood test that is more of a real-time estimation of GFR than creatinine. So it predicts early impairment of function and early recovery faster than creatinine. And the main advantage with that, it is correlated with the risk of mortality. So it has a strong prognostic implication with the serum cystatin C level. But again, it's not perfect. There are non-renal related causes of elevated cystatin C level, namely thyroid disease, smoking, obesity, cancer, diabetes, and chronic inflammation. And lastly, this is rarely done in the clinical setting because it is very laborious, requires several blood samples, constant inulin infusion, and time urine collection. Well, inulin is an inert fructose polysaccharide that is freely filtered in the glomeruli, but it's not absorbed, it's not secreted at the level of the tubules. So, so that would be the gold standard for GFR determination, but it's mainly used in the research setting. So now let's talk about nuclear medicine now. There's several radio tracers that are used, but for the purpose of time, I'm just going to talk about the DTPA, MAG3, and orthoiodohypurate, or OIH, which I'm going to call this for the rest of the talk. So the differential renal function is a very frequent quantification that is used in renal scintigraphy, but it's something that we need to watch out because there's many ways to determine the background, and one popular method is you do a C-shape ORI that's around the lower pole, lateral aspect, and upper part of the kidney to correct for background. And for DTPA, they recommend time for region of interest measurement is between 2 and 3 minutes, and for MAG3, most use between 1 and 2 minutes after injection. And there are two accepted methods to measuring the differential renal function. You could use the maximum slope method, or we could use the integral method, which is the one that we use. Now there's limitations. There's lower accuracy and precision with smaller kidneys and with reduced function. There's intrarenal vascular and extrarenal background, attenuation and scatter, and there's inaccuracy of measurement in patients with ectopic and displaced kidneys. But there are ways to overcome that. So for the small kidney with reduced function, MAG3 has higher extraction in the kidney than DTPA, so better statistics, less inaccuracy in that sense, better, less uncertainty. Now, intrarenal vascular, extrarenal background, attenuation, scatter, the best thing is to pay strict attention to technique and details to maximize the reproducibility. And lastly, with ectopic and displaced kidneys, we can use geometric mean, which means that we acquire the renal scan using anterior and posterior projections. So let me exemplify with this first case here. It's a 23-year-old woman with left renal scarring and previous pyeloplasty at a young age. And we see that the differential renal function is 67% on the left kidney, right kidney, and 33% on the right kidney. And then we see that the left kidney is atrophied on the CT. Now, this another patient who we did around the same time. The right kidney appears to be hypofunctioning, and then the left kidney had 81% calculated split function, while the right had 19%. So, well, I look at the CT, and the right kidney is displaced anteriorly, which is a frequent cause of underestimation of the differential renal function. So that's why, in this case, we did a geometric mean using the anterior and posterior projection, where the geometric mean is the root of the product of the counts in the anterior and posterior projection. And then we obtain a split renal function of 51% and 49% of the left and right kidneys, respectively. But unfortunately, there is some limitation because the geometric mean does not correct for ectopic kidney because of especially the ones that are localized in the pelvis. There is a difference in linear attenuation coefficient in bones compared to soft tissues. So fortunately, that does not happen in very often. The pelvic kidney occurring in less than one case in 1,000, but it's something to be aware. So now let's talk about the measurement of GFR using DTPA. There are other glomerular reagents that we use, but DTPA is the far most common method. So I'm going to go over the multiple blood sample technique, single blood sample technique, urinary clearance, and gamma camera techniques. So let's start with the multiple blood sample technique. There is a good correlation with 8 samples with 2 samples. So it is considered fairly accurate and reproducible. However, it's not the most practical method to use. And then at the bottom, there is a complex formula that I do not want to go over in great details. But we'll talk about the single blood sample technique is the one that we use, and it's less time consuming. And for DTPA, we obtain 1 single blood sample at 3 hours. And then this technique is based on the DTPA concentration at one time point and compared to the injected activity. And using this method, that's how we obtain the GFR, and that is done by Russell and Elias. That was published a long time ago. But there's limitations in blood samples because some patients may have edema, ascites, anasarca, or any terp spacing, and that may cause the overestimation of the GFR. A blood sample at 3 hours is still, means that the patient needs to stay in the nuclear medicine department for at least 3 hours. And also, the ideal blood sampling time is not the same, dependent on the what is the creatinine clearance of the patient, or the GFR. The higher is the GFR, the the shorter is the recommended time after injection for maximum accuracy. Now, urine clearing technique, I haven't seen that done in the practice, but this method overcomes the limitation of third spacing in patient. Is a technique that's based on the rate of DTPA appearing in the urine and is determined by the bladder activity at a specific time after tracer injection and correct for post-bladder residual activity. And you compare this with a single plasma DTPA level. There is good correlation with the 24-hour urine creatinine clearance. However, if patient has hydronephrosis or any significant tracer retention, you could have some inaccuracy in that situation. Now, talk very briefly about the gamma technique. That's a gauge method. We don't use that in our department because you see at the bottom left the correlation between the measured GFR and the Gates method GFR is not perfect, but it does require a gross estimation of GFR, and this method may inspire in the future when we use quantitation using tomography to determine what is the renal function. It's just that with DTPA, the total renal uptake is obtained between 2 and 3 minutes. And we do get regional interest done in both kidneys and background. So the advantage of Gates is simple. It can assess the split renal function. There's no blood sample required. And it's adequate for routine follow-up, according to some physician. However, there's a lot of sources of errors: background correction, the attenuation correction, estimation of renal tracer activity, and it's not as accurate as the 24-hour urine collection, nor the DTPA clearance using blood sample. And for GFR that is less than 30 milliliters per minute or greater than 90 milliliters per minute is not the most precise method of determining the GFR. So it is not recommended in the procedure guidelines in the European Association of Nuclear Medicine, but the European Association did recommend to read this article for more details, and that article does not recommend the Gates method to calculate the GFR. Okay, I'll talk very quickly about this because we're short of time. There are some visual characteristics on renal scintigraphy that can estimate what is the creatinine. And this is one article that was produced on DTPA renal scintigraphy. And they used the three parameters: the peak renal activity to peak aortic activity, the ratio of kidney to liver activity at 2 minutes, and the time of pelvic calyceal visualization. So I just want to go quickly that if the kidney activity is greater than the aortic activity, then this is 100% predicted for good renal function of greater than 70 milliliters per minute. And the kidney to liver ratio at 2 minutes is predicted for greater than 50 milliliters per minute function. And the pelvic calyceal visualization, if you don't visualize it, then there is less than 20 milliliters per minute. I haven't done the study myself, but that seemed to be pretty impressive, the result. And this just to exemplify that the first case shows high kidney uptake compared to the aorta, so the GFR was very good. And the last one, the bottom right, has non-visualization of the pelvic calyceal system, so the GFR was 15, and the one in the middle was in between. Okay, estimated renal plasma flow, I'm getting very short of time, so I have to pick up the pace. It is the tracer that we use in the department, and is MAG3, but historically we use OIH, and OIH, it was first used to determine the ERPF. And then there are multiple measures to determine the ERPF, which I'm going to briefly discuss later. So there's a multiple blood sample method, and this is very laborious as well, because it's obtained using multiple blood samples, and it's not the most practical method to use, but fairly accurate. The single blood sample method is done by measuring the activity, the blood sample. You do a blood sample at 44 minutes, and that is the time where you have the least error according to publications done 4 decades ago. And assuming that the physiology does not change over time, I figure this is still applicable today. So the camera-based method that was produced by Schlegel and that has been validated for orthoiodohypurate, and it has a fair coefficient of variation compared to the blood sample technique, and at 0.87, and that is based on determining the renal activity between 1 and 2 minutes, corrected for the 1 minute count of radionuclide injected. And the camera-based method for MAG3, it has also been proposed, but it has a lower coefficient of correlation coefficient than OIH at 0.80. So that has some work to do. It has not been accepted, but it exists. Okay. Now, this is a modern method of study to determine the renal function of using technetium MAG3 scintigraphy. There is one group that has the MADRE score, which stands for the MAG3 accumulation and discharge rate equivalent. And those group of investigators said that there's 2 components of renal function. There is the upslope, how fast it's upslope. That is one component, and how fast it will empty. And so the higher is the rate of upslope and the rate of emptying, the better is the function. And they have determined that looking on radioscintigraphy, you could estimate what is the creatinine level by the ratio, well, by 3 divided by the square root of MADRE. And very quickly, what's going on? Okay, the renal function is determined by the shape of the renal curve, and if it is upsloping, it is more severe function compared to a rapid elimination. So this has also been done in children with HIV. So the GFR versus ERPF, I'm just getting shorter time. So this ERPF has the advantage of having a shorter time of blood sample after tracer injection. It's generally decreased faster than GFR in renal disease. There's more fluctuation in day-to-day than GFR, and ERPF is less validated than GFR. However, GFR has this opposite advantage and disadvantage compared to ERPF. Now, future perspective, and there are tracers, PET tracers that has been studied to estimate the renal function and provides superior spatial-temporal relationship absolute camera-based quantifications may be possible. So maybe we could use the Gates and Sligo method to piggyback their technique for PET camera-based function. But this is not in the near term, but it might be in the moderate to long term. We might use PET to estimate renal function. So final thought, there's no method to perfectly measure renal function. Radionuclide offers a more instantaneous information on the renal function. It provides differential renal function. Blood samples are more accurate than the camera-based method. And knowing the pitfall may help to identify factors resulting of inaccuracy of measuring renal function. So this is it. Thank you for your attention.